Good morning, good afternoon, good evening, wherever you are in the world. My name is Marlies Ostermann, and on behalf of KDIGO, I'd like to welcome you to this exciting webinar. I'm also grateful to bioMérieux for supporting this educational event. We have two expert speakers who will cover the whole topic of acute kidney injury and COVID-19. The first speaker will be Professor Kellum from Pittsburgh, followed by Dr. Prowle from the Royal London Hospital in London. There will also be time for questions at the end of the talks, and therefore I'd like to invite you to put all your questions into the chat box, and they will be addressed at the end. Without further delay, I'd like to invite Professor Kellum to give a talk on the diagnosis, prevention, and early management of COVID-associated acute kidney injury.
Thank you for that introduction, and this is going to be a presentation on COVID-19 and acute kidney injury. As you just heard, I'm John Kellum from the University of Pittsburgh. These are my disclosures. I may touch briefly on some of the biomarkers, for example, on this that these companies have produced, but that will not be the main focus of my talk. All right, so I'm going to begin by talking about the virus itself. SARS coronavirus 2 produces a disease which has been named coronavirus 2019 or COVID-19. It bears some similarity to two other life-threatening coronavirus infections, SARS in early 2000 and Middle Eastern respiratory syndrome, or MERS, in 2012. Both of these cause severe respiratory syndrome in humans. All three of these emerging infectious diseases are caused by beta coronaviruses. Now, as you well know, the COVID-19 syndrome is characterized by primarily a lung and respiratory infection, but also has extrapulmonary features in many patients, including GI tract symptoms and nausea, vomiting, diarrhea, acute kidney injury, which is often mild but can be severe, and it occurs in at least a third of patients that are hospitalized with acute kidney injury. On the other hand, shock is uncommon, and in fact, when you see shock, you should be concerned about secondary bacterial infections or severe volume depletion or cardiac involvement, which is rare but often fatal. Interestingly, there are other features like loss of taste and smell that are reported by many patients. High-risk populations include those with advanced age, patients who are hypertensive, who have heart disease or diabetes. There was some initial concern about ACE inhibitor use, but that's been significantly, the concern's been significantly attenuated, I think, with additional research, and I'll touch briefly on that later. So how does the virus cause acute kidney injury? It seems as though there are a variety of things that are going on. On the one hand, involvement in the lung and in the vasculature can cause a significant inflammatory response that can be localized to the lung, but often spill over into the systemic circulation. And when this happens, it can affect multiple organs. And, you know, we sort of know this as sepsis. This is what sepsis does, right? It causes a systemic inflammatory response, and that inflammatory response injures remote organs, remote from the site of infection. However, in COVID-19, there is at least some suggestion that this involvement of the vasculature can affect other organs, and there's certainly evidence of that for the heart and the brain. The evidence for the kidney is a little more unclear, or a little less clear. However, there's at least some involvement of the glomeruli, which I'll talk about in a second. There's also this concern that there may be direct viral invasion of certain organs, and certainly this is true for the GI tract. You can find live virus in the kidney, but of course that doesn't exactly mean that the kidney is infected with the virus itself, and that's a mechanism. But there is some concern, at least, although it's still rather controversial, as to whether the virus can directly infect renal tubular epithelial cells and therefore cause injury to those cells. In addition to that, and I'll focus some greater on this in a moment, but there are a variety of secondary cause injury to the kidney through a variety of different mechanisms, which can include the effect of the virus on other remote organs that can then damage the kidney, the effect of drugs on the kidney. And there's also some concern that background genetic variation in the population may influence the frequency of AKI in COVID-19. Now, when there's significant inflammation in an organ such as the lung, and this is what happens in COVID-19, there's often bilateral pneumonia with significant damage to lung parenchyma. Those damage-associated molecular patterns, such as HMGB1 and other molecules, can spill over into the systemic circulation, and the kidney filters these molecules, and these damage-associated molecular patterns, or DAMPs, then can signal inflammation in the kidney. They can also be delivered to the kidney via the peritubular capillary and inflamed circulating inflammatory cells, and interaction with local dendritic cells within the kidney can orchestrate an inflammatory response in the kidney, which can damage the organ. This is what happens in sepsis, and there's some strong evidence now that this is occurring in COVID-19 as well. And we have a long history of understanding that when you have ARDS, regardless of the cause, that acute kidney injury is common. And this has been reported in multiple prior studies with the interaction between the lung and the kidney. Something else that can happen, although it seems to be relatively rare, is that you can have an exaggerated immune response, and this response can cause what has been sometimes referred to as a cytokine storm, where you have an uncontrolled inflammatory response that appears to resemble macrophage activation syndrome or secondary HLH. This is a scenario where natural killer cells become dysfunctional and unable to control the inflammatory response that then becomes rapidly out of control. However, the literature in COVID-19, at least the typical scenario, suggests that cytokines really aren't very elevated, even though they differentiate patients with a fatal outcome from those that have a non-fatal outcome. Nevertheless, the absolute values of molecules such as IL-6 tend to be rather unconvincing, and yet still there's strong evidence that there's a lot of inflammation going on. If you look at serum ferritin or C-reactive protein, particularly patients who succumb to this disease have a very marked inflammatory response as measured by those molecules, even if the cytokines are not significantly elevated. And the best evidence we have so far for therapy for acute kidney for COVID-19 in general is the use of low-dose steroids. Now, whether this also benefits the kidney has not yet been really teased out, but in terms of life-saving effects on for patients requiring mechanical ventilation or even just requiring oxygen, low-dose corticosteroids have been shown to be effective in terms of improving outcome. Now, in terms of the epidemiology of this disease, it was very unclear initially just how frequent AKI was in this population. Reports varied from anywhere from there being very, very little to there being a very high incidence. This is probably the best population-based study that we have. This is from the greater New York area in the United States, where over 3,000 patients were looked at. And I've put the percentages here for you. And by the time this study, at the time the study was published, there were still a good deal of patients still in the hospital. So these numbers may go up, but about a third of patients in the hospital had developed acute kidney injury, with about half of that being stage 1 and the other half being moderate to severe AKI stage 2 or stage 3. And the renal replacement therapy rate was about 14%. Now, interestingly, we looked at our numbers back in April, or actually looked at these numbers in June, but looking at the data we had from sort of our peak incidence in Pittsburgh, a much smaller N, but we had a very similar rate of acute kidney injury and renal replacement therapy. So I think this, these data, at least for us, is very consistent. Now, interestingly, these numbers are identical to what's been reported, and this is some work from our group with community-acquired pneumonia. So the rate of AKI is 34% with community-acquired pneumonia, hospitalized community-acquired pneumonia, not necessarily in the ICU, but just hospitalized. So about a third of patients develop acute kidney injury, and about half of those have what we now would refer to as stage 1. When this study was done, we're still using rifle criteria, but you can see that the frequency is very, very similar. Impact on survival is also significant. So these are data from septic shock, from the process study just published a few years ago. And you can see that mortality goes from about 6.2% at 60 days without acute kidney injury and septic shock to 17% for stage 1 and nearly 30% for stage 2 or stage 3. How does that look in COVID-19? Again, this is the study that I showed you from the New York area. And you can see that the mortality rates, if anything, for COVID-19 look even a bit higher if patients develop AKI. So no AKI, again, about 5.6%, comparing very favorably to what we see in bacterial sepsis, although still some patients hospitalized, so their outcome is not quite clear. And yet patients who develop stage 1 AKI, a bit higher mortality, and certainly for stage 2, 3 AKI, higher mortality still compared to septic shock. Now, I caution you that any clinical trial tends to enroll healthier patients than you find in a general epidemiologic analysis. So these data may still be very consistent, just including some patients that you wouldn't necessarily enroll in clinical trials. Now, in terms of mechanisms, I alluded to some of this already, but the vast majority of patients appear to have acute kidney injury through what we kind of informally refer to as ATN, or acute tubular necrosis, recognizing that's not a pathologic, a histopathologic diagnosis. Like sepsis, due to systemic inflammation and high levels of damage-associated molecular patterns, primarily coming from lung injury, but also end-stage hypoxic respiratory failure, and rarely a macrophage activation syndrome can occur, and certainly has been reported in this disease. But other features like hypovolemia, high incident rates reported in some centers, have prompted concerns for overdiuresis and potential that keeping patients too dry produces kidney injury in greater numbers of patients. I mentioned the glomerular involvement. This collapsing glomerulopathy, a form of focal segmental glomerular sclerosis, has been reported and associated with certain genetic background. And then also rarely cardiorenal syndrome can occur in patients that have cardiac involvement with low EF. And in addition to that, the decreased preload, which can be an issue in patients that are kept very dry, in combination with high PEEP, this low intravascular volume can cause injury to the kidney. Direct viral infection, I mentioned, is a potential concern, although not proven to be pathologic or pathogenic of acute kidney injury in COVID-19. However, the renal tubular epithelial cells do express the ACE2 on their membrane, on the cells, such that the virus can gain entry into the cells, and there is evidence of intracellular viral particles that have been seen with this disease in some patients. I mentioned nephrotoxins. This ninja illustration is a call out to Stu Goldstein's work with children, showing the ubiquity of nephrotoxic drug exposure in critically ill patients, particularly drugs like vancomycin and piperacillin tazobactam, which are strongly associated with AKI. And about 40% of patients in COVID-19 receive antibiotics because of concern for secondary bacterial infection. The antivirals don't seem to have a lot of injury to the kidney. However, they don't seem to be beneficial for acute kidney injury either. Non-steroidals may be used in patients because of high and persistent fevers. I mentioned diuretics already. And there were initial concerns about ACEs and ARBs because of that expression of ACE2, membrane-bound ACE2, and however, on the kidney. But this doesn't appear to increase the risk of acute kidney injury or decrease successful outcome in these patients. Now, in terms of management, we hosted a acute disease quality initiative meeting. As you can see, it was done virtually on a virtual platform, and these results are in press now at Nature Reviews Nephrology, and just briefly touch on some of the management issues for COVID-related acute kidney injury. First of all, the mechanisms that I mentioned were reviewed in this manuscript and divided into three categories: direct viral effects, which where the virus directly causes injury to the kidney through this collapsing glomerulopathy, as I mentioned, but also endothelial damage, coagulopathy, complement activation, and inflammation. But there's also indirect effects, which include the effects on overall hypovolemia, management, mechanical ventilation, nephrotoxic drugs, and organ crosstalk. If you sort of divide those into a total of three groups, the sort of direct viral effects, indirect viral effects, and effects of clinical management, which were grouped together with indirect effects on the prior slide, you can sort of overlay that in this sort of classic KDIGO figure for the management of acute kidney injury, beginning with patients at high risk and then increasing in a stage-based way from stage 1, stage 2, and stage 3. And the colors here just relate to these mechanisms. So standard of care to prevent management multi-organ failure, of course, involves the direct effects as well as the indirect effects, and individualizing fluid management and avoiding drugs like saline unless there's a specific indication or sort of focused on these two mechanisms. Considering dynamic hemodynamic monitoring for fluid management is something to be considered, again, to better manage the fluid status for these patients. To monitor serum creatinine and urine output, of course, so that there can be prompt intervention, correcting hyperglycemia, but not overcorrecting hyperglycemia is important in these patients, considering alternatives to radial contrast if possible. But again, without delaying urgent imaging, avoiding nephrotoxic drugs where possible, but again, making sure that patients receive therapies that are indicated. Consider AKI risks in selecting ventilator strategies. In particular, this refers to using high PEEP in these patients and making sure that they have adequate intravascular volume so that they don't have injury to the kidney in that process. It's important to conduct a diagnostic workup for these patients because, as I mentioned, there are a variety of different mechanisms for acute kidney injury, and as such, they should be treated differently. If the acute kidney injury is coming from a drug, the most effective therapy is stopping that drug. If it's coming from some direct effects on the virus, on the circulation, for example, the treatment is different. Consider alternative pharmacokinetics for many of the drugs that we're using in these patients, including some of the antivirals, which are affected by renal function, and consider renal replacement therapy in these patients when necessary. And then finally, avoiding subclavian access is a general recommendation that we provide for these patients because of the risk of developing chronic kidney disease and needing chronic dialysis, particularly in patients who reach stage 3, and as such, avoiding subclavians avoids the possibility of causing injury and thrombosis to those vessels, or precluding subsequent fistula replacement. So overall, you can think about this as sort of supportive care. The lungs in COVID-19 infections typically have very compliant lungs and are thus susceptible to over-peeping. Prone positioning seems to be very effective in this population, and there's no increased risk for AKI as near as we can tell from the studies that have been conducted to this point, although it does increase inter-abdominal pressure. That does not seem to increase the risk of AKI. Fluids should be balanced, both in terms of their composition, so avoiding saline and using lactated ringers or plasmolite. Too much worsens gas exchange, whereas too little worsens AKI and may promote hypercoagulation. And then renal replacement therapy, which will be talked about in the next discussion. There are many aspects of renal replacement therapy that should be considered. The timing for initiation is unclear, but that's similar to other forms of acute kidney injury. So I would argue then in closing that for AKI in patients with COVID-19, the epidemiology mirrors that of community-acquired pneumonia. The impact on mortality is significant and may even be greater than in sepsis, bacterial sepsis. The pathophysiology is multifactorial, just like sepsis. DAMP-mediated toxic nephropathy is the most common form of injury to the kidney, but nephrotoxic drugs nephrotoxic drugs are quite common. Uncommonly, we have FSGS or this particular form of it. Direct viral infection to tubular epithelial cells is still unclear. And then rarely we have macrophage activation-like phenotype that can occur and be rapidly fatal. Treatment as per other forms of sepsis-associated AKI, supportive care, reducing lung injury will result in less AKI, careful fluid management, avoiding saline and limiting other nephrotoxic drugs, and monitoring for the need for renal replacement therapy so that it can be delivered when indicated and not delivered in the middle of the night under emergent circumstances. So with that, I thank you very much for your attention and hope you enjoyed this first part of the presentation. Thank you very much.
Thank you very much, Professor Kellum. And we will now follow with the second talk given by Dr. Prowle from the Royal London Hospital. And Dr. Prowle will address kidney replacement therapy in COVID-associated acute kidney injury. And again, I'd like to remind you to put your questions into the chat box so that we can address them at the end.
So thank you, Marlies, for that very kind introduction, and thank you to KDIGO for the privilege of speaking to the world about our experiences with kidney replacement in COVID-AKI. My name is John Prowle. I'm a senior clinical lecturer in intensive care medicine and a consultant in ICU and renal medicine at the Royal London Hospital in London, UK. And as I say, it's a great privilege to be able to share some of our experience and deliberations about treatment of patients with advanced AKI with you. So I have a few disclosures I should put on the screen just to be aware, but none of them are directly relevant to the content of this talk. So moving on to kidney replacement therapy in COVID-19. And really in this talk, I want to talk about what the size of the problem is, both worldwide and more specifically in our units here in the UK, what the patient-specific challenges of treating patients with COVID-19 with advanced acute kidney injury are, but also to dwell on some of the organizational challenges for hospitals, services, and indeed health systems in providing renal replacement therapy to individuals during the COVID-19 pandemic and potentially during further waves that may challenge us through the course of the Northern Hemisphere winter that is forthcoming. And in order to contextualize that, I'm going to talk at a little length about our local response here in London as we were challenged during late March, early April and May of this year. So to really look at the size of the problem, we've had a large volume of data being published over the last 4 or 5 months on this, but one of the best papers comes from New York and from the Mount Sinai medical systems, where they were challenged by one of the highest intensity areas of the pandemic in the Western world. And they describe acute kidney injury in over 3,000 hospital admissions, and acute kidney injury affected 46% of patients, but almost 1 in 5 of patients with AKI required renal replacement therapy. That's really a substantial number even for a very large hospital system to be able to deal with. And as you can see, a substantial proportion of these patients were in the ICU, but they also treated a number of patients with more single organ failure related to COVID-19 outside of the ICU. And they had to use a variety of strategies in order to treat this population, despite being in one of the wealthiest cities in the world. There's also been a lot of data from other countries in a number of case series, and some of these were summarized in a publication from the ACUTE group that is very close to press. And on this slide, what you can see is the mortality related to AKI in patients with COVID-19. And as you can see, it is substantial and increasing with increasing severity of AKI. And certainly patients with a requirement for kidney replacement therapy had a mortality in excess of 50%. Now, it has to be said that the mortality that's well described in septic AKI in the ICU is also in excess of 50%. But these are some of the sickest patients we treat every day, and certainly we're faced with an overwhelming number of patients compared to the kind of patient you might say once every 1 or 2 weeks. We were presented with 3 or 4 patients a day, perhaps of comparative sickness. And that produced an enormous burden on systems and obviously an enormous burden of associated morbidity and mortality. So as I've just mentioned, as John Kellum mentioned earlier, experts from around the world met virtually earlier this summer to discuss the management of AKI in COVID-19 patients, and in particular to dwell on renal replacement therapy in this group. And I was part of the subgroup dealing with that aspect. And I really wanted to point out that this was a group of individuals from around the world, including people who'd been at the forefront of treating many, many patients with COVID-19 AKI in Wuhan, in the United States, in Brazil, in the United Kingdom, in Northern Italy, and many other places. And so there was quite a lot of collective expertise in this group, and I'll refer a little bit to that throughout the course of the talk, because that's really the best level of evidence that we have at the moment, although we hope that will mature with time. But really one of the things that came out of our reflections in this group, that there were two different aspects to kidney replacement therapy in these patients. There were the patient-specific aspects of how to do it in an individual patient. That would be, let's say you got one patient with COVID-19 and they were very sick and you want to know how to optimize their treatment, including their kidney replacement therapy, and what aspects you should consider. And then there's the really very different question of how you deal with 5, 10, 20 patients with COVID-19 and how you will provide them with an equitable level of highest quality care that you can provide them with, within the context of the same thing happening in every hospital in your region and in countries around the world who draw on the same suppliers of RRT consumables. And those are two rather specific challenges, and I think listeners might agree actually the second is rather harder than the first. So when we were dealing with this issue, we obviously phrased some questions that we sought to answer in the output of the ADKI consensus conference. And we started with the easier patient-specific questions, and this was really predicated that if adequate RRT is resources available, are there patient-specific considerations that we should think about to do with the typical aspects of kidney replacement therapy prescription, vascular access, timing, modality, dose, and a number of other aspects. And to cut a long story short, really, we felt that many aspects of care, there was no evidence to say that we should be altering from what we do normally, given that we had all the normal resources available. And so we said that we should follow KDIGO guidelines for the areas where there are clear KDIGO guidelines on provision of treatment. But some aspects which are more tailored locally, such as timing of RRT initiation, the modality of acute RRT, should remain tailored to patient needs, and most specifically, your established local practice and expertise, including training of staff and availability of equipment. And to really make the point that trying to do something new in the context of the challenges of an epidemic is inappropriate unless you are forced to do that. And what you should continue to do is do what you're doing well as much as you're able to do so. But we did identify a specific factor of COVID-19 AKI, which goes beyond renal replacement therapy, and that's the really now rather well-described hypercoagulable state, and indeed predisposition to thromboembolic diseases, which certainly anecdotally had significantly affected people's ability to provide effective kidney replacement therapy. And so we felt this should be specifically addressed, and we recommended non-anticoagulant strategies, such as the maximization of the minimization of the filtration fraction by either using continuous dialysis or pre-dilution or hemodiafiltration with a heavier emphasis on dialysis in order to better preserve circuit lifespan in conjunction with specific anticoagulant strategies. And just to reflect on the experience of the faculty of the ADKI meeting that I referred to, we had done a faculty survey where we asked people for their direct experience, and they were asked to grade various different challenges. And the most severe was really them grading something as a major problem that compromised patient care, even with optimization of therapy. And certainly circuit loss and circuit clotting was identified as a very significant problem, or a mission critical problem, by a majority of the faculty. And while other things such as some metabolic concerns were certainly raised, as were the barriers regarding infection control, this was really the overwhelming signal and reflected our overwhelming collective experience treating patients in units where RRT in the ICU was already perhaps quite well optimized given the expert nature of the faculty. I don't have time in this talk to dwell on COVID-19 associated coagulopathy. There are many papers exploring this mechanism, but it's clearly a vascular disease. And this is not surprising, as the lung is an intensely vascular organ, and there's enormous exposure to a capillary bed, potential for endothelial activation, activation of the clotting system, and a disseminated form of coagulopathy, which would have the potential to also affect the extracorporeal circuit. So when we went to our faculty and we asked them what they did before COVID-19, we found, as you might expect, that the majority of the faculty used regional situated anticoagulation or unfractionated heparin to their CRT circuits. But those who did intermittent or dialytic or extended dialytic techniques used a sort of larger variety. But during COVID-19, people changed their practice, and there was a much greater use of systemic heparinization, often in conjunction with regional citrate. And this was extended to patients receiving intermittent as well as continuous therapies. So clearly people were changing their practice, and that's quite unusual. Practices were well embedded and were working extremely well. And one can see our experience of this, because most people before COVID-19 expressed the opinion that their filter lifespan was pretty good, and generally greater than 48 hours. And early in the COVID pandemic, our universal appreciation was that our filter lifespans became vastly worse. But there was also a feeling that steps taken by individuals in different hospitals, and they're often different steps, did improve things. And it certainly is not impossible to apply kidney replacement therapy to patients with COVID-19. There are just aspects that need to be tailored to the characteristics of the disease. So this brings us really to our second question in the kidney replacement therapy aspect of the ADKI results that I'm discussing. What's the optimal anticoagulation strategy for acute RRT or kidney replacement therapy in COVID-AKI? And well, clearly we should definitely be giving all patients some form of anticoagulation. No anticoagulation strategies were very ineffective in these patients. But obviously people have to have the ability to continue to do what they're doing well and just escalate from that, rather than trying to do a new strategy that might actually be suboptimal as it's being introduced in a crisis situation. And so really we said that people should closely monitor their circuit patency so they can understand the question, both in the point of view of the overall service provision and in the point of view of individual patients and tailoring treatment to their needs. And then this would then be coupled by a stepwise escalation of anticoagulation in order to meet the needs of the patient, which might change over time during the course of their illness. And this is the kind of stepwise approach that was suggested and has been adopted in many institutions, including my own, and in ICUs such as Emory in Atlanta, where they've had a big focus on the treatment of COVID-19. And it's about taking your initial good anticoagulation in combination with the level of thromboprophylaxis the patients may be receiving anyway, but be in a position to escalate that initially by perhaps adding more heparin, but as a third line by adding in other anticoagulants and using combinations, and also to consider whether other modes might be compatible with a better overall circuit lifespan and dose delivery in particularly challenging patients. So that kind of concludes my discussion of the aspects pertinent to individual patients. I really want to now dwell a little bit on the key considerations when considering a sudden surge in acute RRT demand in the context of COVID. And we made a few statements on this, and it has to be recognized that intensivists and nephrologists are not necessarily experts in supply chains management. And we certainly need help in being able to provide therapy to our patients and recognize that we are merely treating a group of patients within a region or a country with many, many people with needs. And so there definitely needs to be a coordinated response, and this should be an organizational, regional, or national level, depending by the nature of the emergency. But with an individual institution, we may have a limited amount of resources that we're provided to, and that may require us to adjust the modality, perhaps the level of indication for kidney replacement therapy, and the extent to which we provide anticoagulation as part of a local response in order to maximally conserve the resources available and therefore be able to treat all patients who need therapy. And this shouldn't be saying that we want to compromise patient care. What we want to do is we want to be pay extra attention to providing very good patient care in order to maximize the use of resources. And so just to dwell on this a little bit more, in a pandemic or indeed in another kind of disaster situation, there are a number of different things that can cause a potential crisis in RRT provision. There's increases in RRT demand that's due to local demand of more patients, but also due to increased disposable consumption due to the disease-specific effects, and also due to the fact that perhaps less well-trained staff or the need to use machines for different patients and therefore take one person off and put somebody else in the machine would also cause the increased consumption of consumables. Furthermore, no hospital is acting in isolation, and increased regional, national, worldwide demand may mean there are less supplies for an individual institution. Pandemics themselves could interrupt manufacture and supply chains, and indeed the effect of the disease on the workforce could also compromise the ability to have a trained team with the ability to deliver RRT to the number of patients who require it. And so there's the potential for a perfect storm of increased demand and reduced capacity, resulting in a potential crisis. And such a crisis needs, as I alluded to, a stepwise response that needs to be coordinated both locally and regionally. And there are a number of preparatory responses that need to be put in place when one sees this kind of demands on the horizon. And then there are things that one would institute as responses when demand got close to becoming critical. And then there's also, although it's probably beyond the scope of this talk, a consideration of what one would do in a true crisis situation when one didn't have enough resources to treat every patient who needed it, because that requires a very firm framework, both locally and regionally, to protect both patients and clinicians. We also asked our faculty the logistic challenges they encounter for kidney replacement therapy during COVID-19, and we gave them a diverse range of possibilities. Interestingly, a shortage of medical staff was a very low-level concern, whereas a shortage of trained nursing staff is clearly a much more acute concern. Indeed, some participants regarded this as becoming catastrophic in their units. A shortage of devices was very important, but also a shortage of consumables and fluids. And the two are not identical, and you can obviously have plenty of devices and nothing to run with them, or you can have few devices, but then you might actually be challenged because your use of those devices to treat a large number of patients might actually then consume more consumables. And really what happened in terms of kidney replacement therapy is we did really nearly reach crisis, both in the UK and in the United States of America. And far from running out of ventilators, a number of institutions did run out of the ability to deliver their standard mode of renal replacement therapy to patients who needed this. And this got into the news, somewhat misleadingly. You can see these stories from the UK tending to imply that we're running out of capacity to give maintenance dialysis, which caused some anxiety amongst the end-stage renal failure population, and my colleagues had to go on the radio to disabuse this. Really, we're talking about shortages of the ability to deliver acute renal replacement therapy, but the media has very little understanding of this area, and so naturally conflated this with a problem in the provision of dialysis overall. And in fact, far from end-stage renal failure being limited, in fact, it came to the rescue of acute renal replacement therapy. So I'll conclude there, and hopefully there's time for a few online questions.
Thank you very much, Professor Kellum and Professor Prowle. There have been a lot of questions in the Q&A box. You've certainly generated a lot of interest. Let me start with some questions related to the medical management of acute kidney injury. And John Kellum, you emphasized the need to focus on fluid management and highlighted saline. There are a couple of questions asking why saline, and is there enough evidence to say, sorry, to you advised against saline? And the question is there enough evidence to say saline is causing harm?
So thank you for that question. I mean that sincerely, because I think it's even before COVID, this was a question that I think was very important to our field, right? And so I think that the evidence in support of a potential harm for saline in the setting of critical illness in general and in risk for AKI is something we should be taking quite seriously, because it's a harm signal, right? And it's not like saying one therapy is more efficacious than the other, and then we get into sort of cost effectiveness and all sorts of other things. This is really a question of patient safety. And so if there's an indication that a fluid, that a treatment that we basically provide all of our patients in the setting of fluids has some safety concern, we should take that very seriously. And I think in that setting, although there are still two very large ongoing studies, one that's finished and that we're waiting for the analysis on from South America, and the other that's still enrolling patients in Australia, the evidence that we have to date should give us great pause for the use of saline unless there's a specific indication. And that goes particularly true in the setting of sepsis. That's where the signal is strongest. And I would argue that, as I have in my remarks, that COVID is just another form of sepsis. And so we should definitely be cautious about all nephrotoxins, including saline.
Thank you. There are quite a lot of questions related to inflammation and management of cytokine storm. And it's, I think, if I summarize them, then I'll give them to both of you. The questions are, is there a role for cytokine removal? Is there a role for special filters? And lastly, is there a role for blood purification using any of the various techniques? So I don't know, John Kellum, you mentioned cytokine storm?
So maybe I'll start. I think, you know, this is really an important issue relevant to lots of things we take care of in the ICU. So before COVID, you know, there were lots of other conditions in the ICU in which there were the characteristics of the average patient and the atypical patient. And if you look at septic shock, for example, and we published this in the process study, that the range of cytokine abnormalities that could be present in patients with septic shock range from barely above the normal range to orders of magnitude above what you would anticipate. And we've published some analyses suggesting some genetic variation. There's questions around the type of infection, and there's all sorts of potential reasons why there's variation, but there's really very little doubt that there's enormous variation. And so if you look at the average patient with COVID-19, the average patient really doesn't have much in the way of systemic cytokines, at least not the typical ones that we see in the setting of sepsis, like IL-6 and TNF and IL-8. And that's not too surprising, because this is a viral illness, and viral illnesses tend not to stimulate the same kind of inflammatory responses that you see, for example, from bacteria. However, there is evidence of significant inflammation in many patients, as evidenced by things like ferritin and C-reactive protein, et cetera. It is true that the only intervention that we have available at present is anti-inflammatory, which is dexamethasone. So to argue that these patients don't have inflammation, I think is kind of ridiculous. The question is there so much inflammation that's spilling over into the systemic circulation that you would consider alternative therapies like blood purification? And I think the answer to that is no, not for the typical patient. But there may be subsets of patients that are atypical and have an extraordinary inflammatory response for whatever reason. And in those settings, there are available technologies that can be used and that can be considered and can be effective, at least in removing inflammatory mediators. Whether that translates into benefit will be very hard to ascertain because we're talking about relatively rare circumstances where we're trying to pull out all the stops to save a patient. So I think that's how I would characterize the current situation. And I put it back to you to answer as well, because I think it'd be important to share your thoughts on this with the audience.
I think we also have, before I comment, John Prowle.
Yep, hi, can you hear me?
We can hear you very well. So this is one of many questions, and it relates to the question, should we use special filters to remove cytokines? So you covered filters and techniques.
So in the time that I was allotted, and I probably took more than my fair share of it, I was able to cover kidney replacement therapy in COVID-19. But there's obviously the question of whether we can use an extracorporeal circuit to do more, either while we are doing kidney replacement therapy, such as with a modified membrane, or as a standalone thing, such as with hemoperfusion, as we've been discussing. And I would say that really there's no evidence base for this at the moment. Any use would be inferential, and therefore in the UK that's not something that we have adopted. But other users around the world have developed some anecdotal experience. I would say that the modified membranes have been a little bit more advocated for such things as the removal of endotoxin, and that may not be a particularly important thing in COVID-19. On the other hand, there is the possibility that patients with COVID-19 have gut translocation, and maybe this is a pathway that the cytokine storm might originate in the small portion of patients who might get it. As John Kellum has sort of explained, this is something that's happening to a proportion, but by no means all patients. There has to be a mechanism underlying that. So the answer is no, but further exploration may open up avenues for the selective use of technology, but the use of that technology has to be supported by some kind of rational basis and some kind of biomarker or test or criteria to indicate the group who might benefit from it. And then we have to test it in some form of study. And I think it would be possible to add these kind of technologies to some form of platform study, possibly with an additional entry criteria related to some of the so the inflammation markers that we routinely measure, such as D-dimer, ferritin, and CRP. Certain things have been added to platform studies, such as convalescent plasma or even vitamin C. And you could argue that if those things get into platform studies, then extracorporeal blood purification has equally strong scientific basis to justify its presence on that stage. But I would not be employing these techniques outside of those contexts, because otherwise we just continue to work in the realm of anecdotal medicine, and we know that actually there's a potential for that to really be causing harm when we actually study it in a controlled fashion down the line.
Okay, so we only have a few minutes left, and we have more than 20 questions here. I will pick a few, and I'd like to give us a very short answer. So John Prowle, you shared your experience at the Royal London with us. Did you have any cross-infection? Did staff get infected? And who put in the dialysis catheters in your unit?
So the primary mode with which staff got infected, which was certainly, there was a significant influence of it, and I had positive COVID antibodies, I think was undoubtedly from other staff. And we did excellent PPE with our patients, but we didn't do excellent PPE with each other as we are now doing. And so that was, I think, the challenge. I don't think anybody got COVID-19 from a patient, and many, many people got it from their colleagues. In terms of catheter insertion, that would be routinely performed by our residents. But we also had a lot of very experienced clinicians who came to help us, such as transplant surgeons who were otherwise non-engaged, and they were able to assist us by being a bit of a focused line team. And a focused team is actually probably able to give better adherence to PPE and things like that, because they've got appropriate help and they are focused on doing that task.
Thank you, John. John Kellum, I have a question for you. Well, there are several questions which relate to the role of biomarkers. Essentially, to summarize them, is there a role for novel AKI biomarkers in the management of COVID-19 patients at risk of AKI?
So I think that that's a hard question to address briefly, but I'll try. So I think that there's limited evidence in this population, but the evidence that we have suggests that the negative predictive value of many of the biomarkers that are available is retained. In other words, if the biomarkers are negative, the risk of developing AKI within the next 12 to 24 hours is relatively is quite low. And so many of us use these biomarkers to help stratify patients in terms of risk, and it does appear that that continues to be the case. The other is that when there's a very elevated biomarker that remains persistently elevated, that does in COVID-19, and there's a couple of publications now to show this, suggests that the patient will go on to develop a need for renal replacement therapy, et cetera. And so persistent injury markers, persistent stress markers seem to suggest a high risk for subsequent renal failure. And everything sort of in between those two extremes, I think, is still sort of up in the air.
Thank you. We have reached the end of our webinar. So I'd like to thank Professor Kellum and Professor Prowle for fantastic talks. I'd like to thank bioMérieux for supporting this educational webinar. And obviously I'd like to thank the KDIGO staff for organizing it and providing the relevant support, technical support in the background. Wishing you all a nice afternoon, evening, morning, wherever you are. Bye-bye.
Bye now.
Bye-bye.